Today I will present my IPD case, nutritional management for hyperactive delirium complicated with community-acquired pneumonia CAP with lung malignancy. Hyperactive delirium manifested by patient decreased alertness, slow speech, repeatedly fall back to sleep, never fully awaken, and always in delirium state where there is no pain medication or sedating medication or psychotropic hypnotic medication is absent, and the etiology must be investigated further. Pneumonia is type of lung infection and a common infection that requires to hospital admission to prevent any other breathing problems and other respiratory complication. And community-acquired pneumonia CAP, where the patient infected in community setting and does not happen in hospital or healthcare center. Meanwhile, lung cancer or bronchogenic carcinoma refers to lung tumor originating in the lung parenchyma or within the bronchi. So the patient is 91 years old, Chinese lady, retired, blessed with 6 children. First time referred to dietitian. Underlying is ischemic heart disease, hypertension, type 2 diabetic mellitus, bilateral cystic adenation lesion, chronic kidney disease, and bilateral ovarian cyst. So her diagnosis is hyperactive delirium complicated with community-acquired pneumonia with lung malignancy. For the patient, anthropometry is 160 cm for the height, as patient is not given cooperation for the anthropometry measurement. So height is estimated by measurement of patient lying on the bed, and I obtained 160 cm, and using that I identified ID body weight using the height obtained with the ID BMI at 24.5, so I obtained weight 22.7, the ID body weight for the patient. For the biochemical data, basically urea is low, creatinine previously high but now decreased to low, and other electrolyte is in a normal balance except corrected calcium, which is in high level. Meanwhile, for albumin is low, below normal range. CRP is high, total protein, bilirubin, ALT, ALP, Mg, and phosphate all in a normal range. For the white blood cell is low, hemoglobin is low, but red blood cell is within a normal range. And for the lipid profile, every parameter is in normal range except HDL, which is low. And this is based on 31st May until 4 June. The biochemical data. For the clinical data, patient was admitted from emergency department on 31st May, presented with cough for 2 weeks, reduced appetite, dehydration, and patient refused to eat and must be forced whenever the caregiver want to feed the patient. Patient reported having chest pain and chewing difficulty despite awful danger, and alleged fittings episodes with seizures that could be hypoxic, which is a low oxygen level in the body, no edema, and no ascites noted. Skin is loose and dry, flaky skin. Fat loss was noted on bicep and tricep, and mild muscle loss on quadricep and bicep. And for GI, diarrhea for 2 weeks before admission and occur for 2 until 3 times daily. Only one bowel open since 5 days of admission, which is loose too. And for medication, basically the antibiotics, constipation medication, heart disease, for the muscle spasm, for the mucus and the stomach reflux, and the seizures given to the patient. I proceed with the diet history. Patient regular diet is 700 kcal, and her favorite food is fish and dislike to eat chicken. But since admission, the intake decreased significantly, and a day before RC insertion, there was no intake at all. Usual diet history depicted insufficient intake of protein and source of food in high fiber. She took plant omega for a long time and suggested by family for her, as she believed that helped in her hair growth, and recently started to take HDM as oral nutrition support. She refused to eat and drink and has to be forced by family member. So on the bedside there is observed oral nutrition support, which is plant omega, and consumption are very minimal in the ward. The nutrition diagnosis for the patient is inadequate protein energy intake related to refusal to eat due to the current clinical conditions, psychologic metabolic as evidenced by very low intake energy and protein intake less than 75% than requirement. For the requirement, dosing weight is used based on the usual body weight, 62.7, and energy obtained is 1,500 using 25 kcal per kg, and protein is 1 kg per gram, so the requirement for protein is 62.7 gram, and both this energy and protein is based on Aspen 2022, and fluid is based on 25 ml per kilogram, so her requirement is 1,570 ml based on ADA 2021. Main goals for the patient is to optimize nutritional status to meet at least 75 until 80% of energy requirement, and nutrition prescription is enteral feeding 1,500 kcal glucina. So I will start with step 1 with the 2 scoop glucina 80cc, 50cc flush. Step 2, 4 scoop glucina 160cc with 50cc flush as well, and step 3 is full feeding, 5 scoop glucina 200cc, 50cc for flush, and full feeding will provide 1,575 kcal, 70.7 gram protein, and 1,750 ml of water. And the monitoring and evaluation will be biochemical data, toleration to the oral nutrition support, IOCHART and dextrose. Based on my follow-up on 6 June, patient tolerated well to the step 1 and step 2 of the initial feeding regime, as patient tolerated well with minimum aspiration 3 until 4 cc and no GI symptom. Full feeding, which is 5 scoop, was proceeded at 3 p.m. on the same day, and patient also tolerated well for the full feeding. IOCHART was positive balance, and there were no significant spikes of dextrose reading. So I found a new diagnosis for the patient on the typical day, on the particular day, which is inadequate protein energy intake related to feeding optimization volume, still inadequate, as evidenced by only 30% of the energy achieved as a latest initiation of enteral delivery. My second follow-up is on 7 June, as patient tolerated well to full feeding with minimal aspiration and no GI symptom. IOCHART was positive balance, and there were no significant spikes of dextrose reading. Previous nutrition diagnosis resolved, and no new nutritional diagnosis found at the moment. I think that's all for me. Thank you so much.